Hi, everyone. Welcome to the Superfeeler podcast. My name is Lori, and I'm very excited today to be joined by Maggie Flynn, who I met at the International Society of the Study of Personality Disorders conference in Boston last year. And we were in the same time slot for presenting. And so I got to see her presentation, and it kind of blew me away. It was one of the things that I took pictures of all of her slides and was trying to explain it to my husband when I got home. And I didn't do a very good job, so I'm excited for you to explain it. But it was really interesting and I think easy to implement into people's lives. So I'm excited for that. And then I also recently hosted, we have something called Skills Lab, which is like a peer support session where we talk about a specific skill every time. And we were doing self-soothing last week, I think it was. And I was like, oh, you know what? I heard about this amazing thing about incorporating this kind of sensation seeking into your life on a daily basis. And then I, again, tried to explain it to people and was like, okay, I did not do a good job of that. Let me try and get Maggie on the podcast. So I appreciate you coming on, and welcome. Do you want to just tell us a little bit about yourself and what you do?
Yeah, thanks so much, Lori. I think that's just, after we met at the conference, I know we had connected a little bit about it, and I'm really, really excited. I think it's some really cool and powerful work that's unique, given the role of OT in psychiatric care. So yeah, I am an occupational therapist, which many people think, why is an OT working in psychiatric care? Or oh, are you working with people who, have hand injuries or other things? And often compare us to physical therapists, but our roots, mental health, OT is actually the roots of our profession. And so I don't know if you want me to go into the history at all.
Yeah, I would love to, because I actually didn't know that.
Yeah. So OT is actually, after World War I, during World War II, when folks were coming back from war, particularly men, there was a lot of, at the time they called it shell shock, or what we know now as PTSD. And it was really impacting people's function. So they were looking at, their physical ailments, and then some other folks who weren't able to function, weren't able to go back to work, weren't able to maintain their households in the same way or care for their kids in the same way that they were prior to going off to war. But there was nothing physically, right? There was nothing physically that people could attend to. And then they worked with psychiatrists and psychologists, and OT started to drum up this idea that when people were engaged in purposeful, meaningful activities or purposeful, meaningful things, it was a opening or a door to really understanding the person, connecting to what was valuable to them, and really allowing them to function to their best ability, but also in a way that was not just talking about how they felt. So
yeah.
Not very many people know about what psych OT is. I think some people who work in occupation or who are occupational therapists sometimes don't even fully know what psych occupational therapy is, or its realm and scope. But yeah, I've been an occupational therapist for about 6 years. I graduated during the pandemic. I graduated in Boston at MGH Institute of Health Professions. So I have my doctorate in OT. And I went straight into psychiatric care during the pandemic, which was really an interesting time because psychiatric care, as we know it, is off inpatient, at least, is in groups. And so pandemic groups, it was a whole interesting thing. It was stickers on the floor of where people were supposed to sit and stand because we still had to be social distancing. And yeah, so I've worked in psychiatric care for the full breadth of my time outside of graduate school. And I've been doing program development and really trying to have folks throughout the U.S. because I think now that we've transitioned to, unfortunately, a model of healthcare where, it's not really based on can somebody actually leave and function? It's are they taking their medications here? Are they, stable? Okay, let them, leave and go back to the community.
Can we get them out the door, basically?
Yeah. And it's not a money, OT can be a moneymaker, but they don't really see it that way in our lens. So yeah, it's a part of the profession that, and a piece of the puzzle or the pie, I like to say, in healthcare, particularly in psychiatric care, that I think gets missing. And I am really excited to talk about some of the work that I've been able to do and some of my colleagues have been able to do, in the realm of working with folks with borderline personality disorder. So
That's amazing. Thank you so much. I love that context because I'm kind of, there's OTs in some of the program areas that I work in concurrent disorder, like mental health and substance use care, but I'm not specifically connected to their work. And then my husband works in car accidents. So
Yeah.
there's OTs involved in that all the time, but not the psych OTs. So it's like a very cool history to have. I had no idea. So you started doing research around borderline personality disorder, and I'm curious, was there something that drew you to this population?
I think one of the things, and I kind of brought this up, I think, during the presentation, is just or our lens is so much focused on the values and the core of treatment being the person, like the human. And as you know, and what a lot of the conversations around, the work that you are doing and other folks we talked about even at the conference was like the stigma around BPD. And it really, really, I'm going to use the word like irked. It probably
Yeah.
stronger words than
Yeah.
I don't know if I can say on the podcast.
You can say whatever you want, but yes, I feel you.
It just really hits me hard when treatment and care that we're providing to folks in any capacity is impacted by this stigma or this lens of judgment around a behavior or in any regard, or even just the label of the diagnosis. And so when folks were engaging in self-injurious behavior and engaging in, what we call maladaptive or just like unhelpful behavior, I'm like, this is not serving their function. And by saying to folks, well, that kind of sucks that you're doing that, but that's a part of your diagnosis. And that's just you're engaging in attention-seeking behavior or manipulative behavior. I was like, well, we work in a behavioral health setting. Like, this is a behavior. This is something that we're supposed to be addressing. And that just really, really got to me over time, seeing just anyone engaging in a certain behavior that was labeled as something that we couldn't support because of a lens that they were taking, and that stigmatized, judgmental, biased lens. And so I was like, okay, well, I know what I can do in this space. I know what I can do with my skill and my expertise and my background as an occupational therapist. And so I just started doing what I knew how to do, which is assessing and evaluating why folks were engaging in this behavior, and then using my profession's assessment tools to assess their sensory preferences, why they might be, engaging in this behavior informally, formally. And we just started coming up with the same pattern over and over and over again. I was like, there's something here. We have to dig a little bit deeper into this. And so that's kind of what kickstarted it. But definitely the stigma that I was witnessing that really hit me to be like, well, this is not helping. This is not helping us work with this population, nor is it helping the person who's going through it. So that's what really struck me.
Yeah. I mean, I think it kind of comes down to you trying to answer the question that everybody's had, which is, why do people self-harm? Why are these non-suicidal self-injuries even a thing? And I think in a lot of ways the stigma plays into that, because we just assume that, like, well, you're doing this because you're not capable of doing something else, or you're a bad person and you're trying to manipulate us, or you're trying to get attention, like you said. And then people don't actually try and get into the, like, but what is this serving for the person who's doing it? Because, I used to self-harm, and it's something that I think about often, and there's a purpose to it, right? I'm not saying it's the right, like, I'm not saying, I don't even want to put the right thing to do judgment on it. I'm not saying it's the most, like, conducive to, like, or like productive thing that you could do. It's certainly not. But at the end of the day, there is a purpose to that for individuals. And I think everybody that's ever self-harmed has been asked, like, but why are you doing this? And it's really hard to answer that question on your own. But I think some of what you found really shows, like, because there is this need for some sort of sensation.
Yeah, yeah, and I I think about the first one or two times, and I'd worked with adolescents a little bit, as well as adults early on in my career, which we didn't start tracking some of this until about 4-ish years ago. So this was pre
Hmm.
me working on the adolescent unit, but I just recall the first time that I started really digging into this, and this young girl said to me, she goes, "No one's ever even asked me why, like what I get out
Oh,
of it." And I just, I, I paused and I was like, so, like you said, so quick to judge, so quick to have that bias, that lens, and to not even really take a moment to understand and to not just to understand, but to give that space of like empathy and compassion in that space, really struck me too. And so, yeah, I don't know if there's any other specific things you want me to get into, but I think that the sensory piece, we think about, sensory modulation, or this idea of taking what we're experiencing internally and externally, and I'm going to use the word modulate, but
yeah.
basically take all of that input and figure out how to regulate, and how to manage that. And I know you were saying about self-harm, being like bad. I don't even,
Hmm.
like you said, it's like the judgment is can obviously be a part of it, but I often keep to this word of functional, right? Is it functional?
Yeah. Love that.
And so, you know, there's so many ways that, the space of harm reduction, but also the space of, okay, what's going to be more functional that's still going to get your needs met, that you don't have to engage in something that could really, really harm or affect your body long
Hmm.
term, but give you that input, environmentally, externally, or internally, so you're able to continue to go and do the things that you want to do and the things you need to do, because that's what's most important. So,
It's
yeah.
funny. I also did a peer support session last week around the effectively skill in DBT, which is basically like, I mean, I'm not going to describe it very well, but like getting to, like, what's your goal and getting towards that goal and doing so in a way that's effective rather than like what you want to do. And sometimes I think in a lot of ways that comes down to self-harm, because you might want to self-harm, but is that actually getting you to this larger goal that you're trying to get to? Is it just helping you in this exact moment, but then it's going to harm you in an hour when you have to shower and your whatever injury you have really hurts, because it does? That's something that, like, there's so much around DBT that can help us take that pause and then think about like the longer term consequence of the
Yeah.
short term action. Could you just describe, just because I you sent me your slides, which I really
Hmm.
appreciated, and even just reading the slides back, I was like, okay, I'm still a little bit lost on like some of these big words that you used.
Yeah.
So
Yeah.
like, can you describe maybe like what your study was
Hmm.
and how it worked, and then what you found, just like from start to finish?
Yeah. 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 So it's not. I say. I'm really grateful that you're saying considering it a study, because I feel like we've just like accumulated all of this data, and it like and all the patterns align, and
That's
yet
great. Yeah,
and
that's
yet
research.
yeah, right. So we had, because it's a part of the practice and care that we're providing as therapists, we didn't have to, go about getting all of this, the IRB and all that
Yeah,
other jazz.
perfect.
But which is great, makes
Yeah.
my life and the lives of others that much easier. But essentially, what we what was going on, or in behind the scenes, uh, and then forward within the scenes, I guess, of treatment, was starting by getting referred. So we would get referred as OTs, or we would jump in and say, if somebody is engaging in any type of self-injurious behavior that was non-suicidal. So if they
Right.
were
Yeah.
not engaging in a behavior that, from anything from head banging to cutting to picking or whatever it was. And even if they had urges, but they weren't acting on them in the moment, we would still.
And this is an inpatient.
Yeah.
Psych.
So this was, yes.
How long are
inpatient.
they there usually?
It really depends on, like, I've worked with folks who were there for 7 or 8 months, and there's some cases that I refer to in the slides that folks where this work really made an impact on them being able to leave the hospital versus going to a state hospital, and they were young folks in their early 20s. So to think going from a hospital to a state an inpatient psychiatric setting to a state hospital for who knows how long at that point, versus going home with your family and your dog. So the work seemed, like I said, that much more impactful and important, and why we wanted to continue to push for assessing and evaluating folks so that way we could provide the intervention. So I'll start rambling, but we essentially we used what's called the adolescent and adult sensory profile, which is essentially a questionnaire. It's a little bit, I don't want to say outdated. They're just revamping it it hasn't been updated, I'd say, since I think it's like the late 90s. But it's a cool tool because it's a questionnaire. And even though it's a self-reported questionnaire, even just gathering that data to understand why somebody, how somebody likes to, it asks questions all through the senses. So from like smell and taste to movement to touch to hearing, seeing. And essentially, it breaks your preferences. So it's not diagnostic. And I say that to folks all the time. It doesn't diagnose anything. Anybody can anybody can complete the assessment, and it tells you how you process your sensory system processes things coming into it and what you're feeling internally. And so it breaks it down into scores, then in 4 quadrants. So 3 of them are kind of more self-explanatory, and then there's one that really speaks to the work that we were doing that people often don't regard or don't consider when working with folks with really any folks, because it contradicts the other 2 scores that end up being high. So there's 4 quadrants, and you can either score really low compared to most people, similar, or much more. And so there's sensory seeking, which I know you said seeking earlier, but it's actually there's another part to this that's why people are seeking some of this input out. And it's not the sensory seeking piece. So most people actually with BPD, and we found with trauma as well, and most of the folks we assessed had co-occurring trauma and BPD. But the sensory seeking was much less than most, or actually similar to most. And then the other 2 quadrants that folks with BPD scored high in were, or I should say not the other 2, the 2 that were most prevalent that we often think about with trauma and folks with BPD is sensory avoidant and sensory sensitive. So people so sensory sensitive is that idea that somebody slamming a door, or somebody playing really loud music while you're trying to focus on something, or the tags or like the fabric of clothing that most people would be okay with. Folks who are sensory sensitive or high in that score, their system just picks up that sensory input much more easily than other folks. And then the sensory avoidant folks also scored high in, kind of matches with that sensitivity, right? If you're a sensitive to input, or it's more, what's the word?
Pronounced,
pronounced. Yeah, you're getting this feeling that's like, oh, okay, I don't like this, or this is uncomfortable. People tend to push that away, right? And that doesn't mean that if you're sensitive that you do avoid, but those 2 high scores are often paired together. And so we saw those two scores, sensory sensitivity and sensory avoidant, really high in folks with BPD. But then this other, the last quadrant, which is the more, the one that people are like, what does that mean? Is low registration, which means just that your brain or your body needs more sensory input for your brain to register that you're experiencing it. So I kind of give this example, like if somebody's talking, this is just one example. Somebody's talking to somebody else and I'm calling their name, or I am just touching their arm. They might not register that I'm calling for them auditorily or touch. I might have to like tap their arm, or like give them a little bit of pressure, or say their name louder, or do something else to get their attention. That's just one example.
So that's low registration.
Yeah, that's high scores and low registration. So it seems to contradict itself, right?
It does,
the idea,
because sensory. Right. Sorry, what was the second quadrant you talked about? Sensory
avoidant, sensitive and avoidant. Yeah.
So you would think that if you were high in sensory sensitivity, you would also be high in registration, but it's actually the opposite.
So you're high in sensitivity, you're high in avoidance, which matches, and then the low registration is high, saying you need more sensory input for your brain to register it. But it's
so it's
like
kind of a double negative,
yeah. Like you're kind of conflicting.
Weird.
So the idea behind why we started to explore is because we often see as clinicians folks with trauma or BPD having a very small, I could say, like window of tolerance, meaning like something like you're comfortable one moment and then, oh my God, whatever it is, just feels really, really intense or really big. It could be inside, outside, whatever. And I was like, okay, well, this kind of makes sense, because 9 times out of 10, when I talk to folks, when they are self-harming or engaging in self-injury, it's because they're just dysregulated or distressed, or something is uncomfortable inside, like a feeling inside, or something in their environment is distressing. And so we looked at then this low registration piece, the high scores and low registration, because people would, the sensitivity and avoidance, they would pull away or retreat or isolate, but then they weren't getting this high score and low registration need met. They were isolating or retreating because they were, like, I don't want to engage in that, or I'm not gonna, put myself in that position where I feel that way. But then the low registration needs weren't being met, those high scores. So their body didn't feel safe or grounded, either in a distressing moment or throughout their day. They didn't feel grounded.
I was going to say, what would the need be for low registration?
Yeah. And it can vary. That's a really good question, because it can vary person to person. And so that's why when I go through, it varies person to person, and I go through the scoring, because like I was saying earlier, the the assessment tool breaks it down into different sensory categories. So like taste and smell, movement, activity, hearing, seeing. And so I look at, okay, what are the scores that are not as high in sensitivity and avoidance? So what are the things maybe they're not as sensitive to or avoidant to in those areas?
Right, because that could be you're not sensitive to smell at all,
right?
But you're really sensitive to hearing or something.
Exactly,
okay.
Exactly. Yeah. And we didn't really look too much at the categories, but I would say this is maybe more a little like anecdotal from our experience in creating, which I'll talk about, those sensory lifestyle plans, those things that we were working with folks on to develop after we talked to them about their results. But we found a lot of times that the low registration needs were not being met for what we call proprioception. So proprioception is different than touch. It's pressure, weight, muscle resistance. And so a lot of people with trauma or BPD don't like not that they don't like, but they're sensitive or avoidant to like touch or light touch, but deep pressure touch or weight or, like I said, muscle resistance. So that's like when you're like
Pushing on
tensing,
something.
tensing your muscles. So that's all
Yeah.
tied, right? We were talking about DBT earlier, the
Yeah,
progressive
totally.
muscle relaxation, paired muscle resist. Like that's what it is. And so the touch piece being different than proprioception, folks needed more, sometimes more input in that realm of what like I said, proprioception, and they weren't getting that need met. So the pressure of banging your head, the pressure of hitting yourself, the pain sensation of cutting or burning, whatever self-injurious behavior that was coming up, we noticed that the proprioceptive or that pressure, weight, muscle resistance input throughout the day for folks was low, and they were getting that need met by engaging in self-harm or self-injury.
Sorry, just to
Yeah.
clarify.
Yeah.
So proprioception is the deeper sensation, the pushing, deep pressure, whatever.
Mm-hmm.
And that they were getting met by self-harm?
Yeah, when we ask folks about I mean, again, this varies person to person. Some people
Yeah, of
liked
course. Yeah,
the way
everyone
that
does.
self-injury, the way that it looked or the way that it smelled.
Right.
But the release or that sense of, I think about progressive muscle relaxation in particular, right? Like you tense your muscles so tight, and then it's like you force the relaxation, you force that release, and that's proprioceptive input, and that's really what the self-injury was prompting. This, a lot of times people were saying like it's a relief, it feels like a release, and it's essentially creating this tension or this tense moment and then forcing the relaxation. So more often than not, a lot of the intervention or a lot of the treatment was around trying to get more proprioceptive input or that pressure, weight, or muscle resistance input more intensely or more often throughout the day, so that when somebody was in a distressing situation or, the time of day mattered, sometimes like evening, it was really difficult, that people weren't in this like knotted up ball where the only thing that was going to give them that release was that self-injurious behavior.
Right.
So that's really what we looked at. And I always give this little analogy of like, and we can talk, I guess, about the sensory lifestyle plans, which is kind of like how we not just looked at the results, but then how we, interacted
actually
and engaged.
Implemented it,
Like actually implemented it. But essentially that low registration piece is having the body need more sensory input in order to feel safe and grounded, or regulated. And so people with BPD and trauma, not very much research is obviously, that's why I'm trying to do this and hopefully, write a manuscript at some point.
Yes. Story of my life, literally. I'm like, I need to publish so many things.
I'm like, oh, okay, when am I, if only work had sabbaticals.
Yeah.
The idea that sensory sensitivity and sensory avoidance is so highly pronounced in the literature, and around PTSD, even a little bit around BPD that we found when we were starting to look into this, but there's nothing on low registration, and it's I say crazy to me, but it's insane to me how doing this research, because of how many folks at the time when we presented at the ISSPD conference, we had 20 something people, 21, 20, I forget what the slides I sent were. But now we have over, even since then, and that was, when was that? Fall?
November, yeah.
Yeah. We've had at least 10 or 12 more folks with the same pattern. And so, it doesn't mean that everyone who has BPD is going to score in this pattern, but it's such a denoted objective way of looking at self-injury and a non-suicidal self-injury and how to intervene. Where you're like, okay, like, this is so, people aren't talking about this. I don't know why people aren't talking about this.
Did this come up at all in the research around autism with low registration?
Yeah. So yes, but oftentimes, and the literature is pointing more at, instead of it being low registration, it's sensory seeking. So often folks with, again, we didn't have, I think of the folks that we've evaluated and assessed, of the 30, I think it's at like 33 or 35 now, culminated, only 2 folks had a formal diagnosis of autism. So I don't think that's really enough to say that it's in our research and literature that it's also folks with autism. I'm sure, obviously, it's, this all ties back to, neurology and our neurobiology. And I think that's also an interesting thing of how non-suicidal forms of self-harm are just now being looked at from a neurological standpoint. I'm like, this is like, it's a body response, the way that the person's trying to cope or manage in their body, and you're not looking at the neurobiology of this. Like, you're just looking at, again, and I'm not, I love psychiatric care, but I'm not putting the psychiatrists and psychologists down, but I'm like, you have, like, the brain, you don't just like carry your brain around in a fish bowl on the side of your body. Like, it's connected to your brain, it's connected to your brainstem, which is connected to your spinal cord, which goes through your whole entire body. So it's crazy to me that folks aren't looking at this, or just now looking at this. But to answer your question, there is some research, some literature solely on autism. I haven't seen anything related to this with co-occurring psychiatric diagnoses.
I just think about like autism and having that sensitivity to external stimuli, likely some avoidance of that stimuli, and then also behaviors similar to what you're looking at around like headbanging and stuff. Yeah. Which, so like, that would just be an interesting kind of thing to look into. Yeah.
Yeah. And I wonder too, like every human being, but the saying of, you meet one person with autism. I think that just you meet one person, human being in general, you meet one person.
Yeah, 100%.
But the idea that I would say more literature points to in the engagement of headbanging or stimming of folks with autism as sensory seeking.
Yes, that's what I was thinking.
Whereas we're finding folks with trauma and BPD on the low registration end. So the reason for engaging in the self-injury is not necessarily to seek out the sense. It's more of a way for the brain to register that they're experiencing feeling the sense of their body, right? Because it's really distressing. I can imagine. I mean, I don't experience this, but to empathize and to feel in that space, your brain and your body feeling disconnected, and that's people will say dissociation, or just the
100%.
idea. Just even if you don't identify that as dissociation, just the experience of your brain and your body feeling disconnected, or you're not feeling safe in your body. That sense in and of itself is distressing. And so if you're feeling that more throughout your day than the average person, and then you're not getting it met, and the only way that it feels like you are getting it met is through self-harm, it leaves that space, I think, a huge window of opportunity for us to engage with people in a more functional way. Because that's not, I don't want to say that's not functional to live that way, because that's even judgmental. But I don't think I've met a person who wants to live with their brain and their body feeling disconnected all day long.
Or self-harming every day. Like, isn't something that, like, yes, like, we do it in a coping mechanism, but we would rather not, usually. Obviously, again, everybody's different, but generally speaking, people would prefer not to be doing that in the long run when they are emotionally regulated. So there's two different paths I have here. So the dissociation thing's really interesting, because I can kind of see the dissociation and the high low registration scores making total sense, right? Because like, sometimes when I'm dissociated, and I don't experience a ton of dissociation, but when I do, like, you could punch me in the leg and I wouldn't feel it. Literally. Like there are days where I'm like, I can't feel my entire body. So you would need something a lot more intense to be able to get out of that than just like gently touching right? Because
Mhm.
you actually can't feel it. So that to me,
Mhm.
I think makes sense.
Mhm.
And then the second thought that I had was, do you know, I guess it would be anecdotally, like why self-harm meets that need compared to something else?
Yeah, I mean, I'm just trying to think of other ways you get that intensive input
Yeah.
without it being harmful, and that's why I think OTs are at this really unique, what's the not climactic point,
Crossroads?
but yeah, or at this point where it's like, okay, we can actually address this because we are. I don't want to say we're. I think most OTs are very creative, and so
Yeah.
taking this idea that it's like, okay, well, so I'm just thinking about a client that I just was working with, and having urges to bang her head. And I was like, what do you get at? She's like, oh, well, the pressure input and the movement. So I had her hang upside down in the rocking chair in our sensory room,
Mm,
and all the blood rushed to her head. And then she's rocking in that a similar motion of banging her head. And she was like, oh, this feels so good. And I was
right.
like, what other person would tell you to hang upside down in a rocking chair, you know? And I'm like,
Yeah.
okay, that's pretty cool. To be able to think in that as a clinician to think, okay, I'm helping somebody by having them hang upside down in a rocking chair to
Yeah.
reduce their self-injury. Um,
That makes total sense though.
yeah, right?
Because if that's what your sensation is, you're just doing it
Yes.
differently. Love that.
Exactly,
Yeah.
exactly. So there's so many, like, things that I tweak in, taking really exploring and understanding what is the benefit or what and that's part of that intervention. So once we assessed and evaluated, then we kind of had this procedure, if you will, that I sort of I don't say gently. It's like a rough procedure of what we were doing then at that point, of what questions we were asking the person and what ways we were then going to create intervention around it. And so some of the questions were, what sensory things do you like about that? What do
Mhm.
what are times of day or distressing situations? In limiting not to, because if you ask people everything, that they're going to list tons of. So I said like 3 to 5, to keep it to like the higher moments of distress, times of day or situations. I asked about what things do feel soothing. So if they could identify anything that felt like calming to their system, an activity or a sense, and then anything that felt energizing or alerting. So I'm trying to understand like what things give them energy or are alerting versus soothing. So on that spectrum of what things are gonna like almost not put you to sleep, but really feel like safe and comfortable
Yeah.
whereas what are the things that are going to not set you into a spiral of distress, but what things like wake you up and feel energizing. And so we'd ask some of those questions and then we'd come back together and really then start to be a really collaborative process of, okay, so we want to make sure we have some things in the morning that are grounding but energizing and alerting because we don't want to be doing something that's soothing unless that's something that's a really strong coping skill for that person
Mhm.
and they want to do it in the morning because we need to do things that are alerting and energizing while also grounding. Same thing kind of goes for the middle of the day, balancing those two things maybe a little bit more. Right in the morning, we want to do something that's going to wake the person up, but also feel grounding. Because a lot of folks wake up, and I use this analogy a lot when I'm talking to any person who waits to the end of the day and then they're like,
They
which
blow
I
up
do
or
too. I
whatever.
can't, yeah,
Yeah.
I mean, we all do it in some way, shape, or
Yeah.
form.
Food is
And
a great example of that. You're
I'm,
like, "Oh my god, I've eaten so well all
yes.
day. Now I'm going to eat nachos for dinner." Yeah.
Well, not even that. I use this example of eating or not eating, in this way of like if you woke up in the morning and you were a little bit hungry, or a little bit in a knotted ball, like in terms of distress. So the kind of these two parallels of not eating and waking up a little distressed, and then you're like, oh, I'm not that hungry, or I'm not that distressed, and so you don't do anything, and then it's middle of the day, and you get this like meeting or you get this assignment or somebody, nearly, hits you on your drive to work or you're stuck in traffic, whatever it is. And then you're still a little hungry, but you're like, oh, I have a work meeting. I don't eat lunch. So kind of these two parallels of this analogy. And then you get home and you have nothing prepared, like you have nothing in your fridge. And so you're like, oh my God, I'm starving. And now I have to like wait to either order something and can't think about what I want to order. And then, I might just eat whatever's around, like ravenously. And then the same idea with that, like knotted up ball, you're stressed, you get home, maybe you have like, roommates or your kids or your, dog puked on the floor or something. And you're
Yeah.
like, oh my God. And then it just, end of the day, evening, and it just like blows up, right? And it feels like it's blowing up. Whereas if throughout the day, if you were eating throughout the day
Yeah.
or addressing your distress throughout the day in various ways, yes, you might still come home to the dog vomiting on the floor or, your kids screaming or whatever distressing thing that's coming up in the middle or evening of the day. But your threshold or this, you've built up
Mhm.
this bank of regulation.
Yeah.
So that way you're not starving or this balled up yarn of distress by the end of the day. So, or in a distressing moment. So that's really where this idea of the sensory lifestyle or sensory interventions throughout the day to prevent those not only the behavior, but when the distressing situation comes or the evening comes, because that was a high time
Yeah.
for folks to self-harm. You might have a little bit more in your bank, so that way you could choose something else, or
Yeah.
you could engage in something else that was going to be, I don't want to say as satisfying, but meet those sensory needs in that moment.
Mhm. And I'm sure that there's also part of just having some sort of a routine, like of practicing different ways of getting that sensory input that makes it easier to use, right? Because
Yeah.
this is the thing, if you only ever practice your skills when you're distressed, then it's going to be really hard to practice them. But if you practice them every day when you don't need them, but you could use them, then it's so much easier to use.
Yeah. Yeah. I don't know if, I use the analogy of Tom Brady. I don't know how relevant that is in other parts of the world other than New England. But just like anybody who's good at their craft,
Yeah.
whatever you're doing, whether that's a, professional musician or an artist or whatever, they don't just sit, or an athlete, they don't just go into game day not having done anything in their routine or in their day-to-day life. And they're like, oh, I'm ready for game day, or I'm ready for this
Yeah.
big, concert or whatever performance. It's built into their day. It's not every single moment of their day,
Mhm.
but it's a routine that they're engaging in that supports them to handle those moments where they're heightened or you're expected to perform. And I guess in that analogy, the performance is just something distressing or something that's going to alarm the body. So you feel like you're, as prepared as you can be.
Mhm. Yeah, it makes total sense. So this sensory lifestyle thing, can you explain what that means?
Yeah. So the sensory lifestyle, after we have that conversation, so now we've done the assessment and we've had the conversation about the results, and we do this in a very like layman's terms way, just kind of like what I hopefully enough layman's terms of me sharing with all of you. And then we ask the questions, and when we get, then we work on this collaborative process of creating the sensory lifestyle. And so it's really that, like, what are some things in the morning? What are some things in the middle of the day? And what are some things in the evening? And then in that same breath, and it's not just because I love food so much, but they used to call it a sensory diet, and then they shifted it to sensory
Mm.
lifestyle, which I like. I do like, but I do like this idea of this when it had the sensory diet. It was like you had sensory snacks, which were like the
Yeah.
things when you were really craving, right? When you're really having a tough day, or you're really everything's going wrong, or you're just
Mhm.
really having the urge to engage in self-harm. what are some things that are not necessarily built into your everyday routine for sensory input that you could kind of have off to the side as like a crisis snack type of thing.
I love that snack bit. Yeah.
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 So to that same idea of, what are you, doing in the morning? What are 2 or 3 activities in the morning? And these are things that are not necessarily life altering. They I think, and from what, folks have shared, life changing in the sense of how they feel, but they're not, you know, go for a 5-mile run at like
Yeah. Yeah.
6
Yeah.
a.m. It's like, you know, after you're done showering, wash your face with an ice cold
Mm.
face cloth. Doing 5 to 10 minutes of intense, I say intense muscle exercise, but this could be like stretching or like holding certain isometric positions, so like wall sits or something like that. What are some other things? Even folk like eating something uh, that um is sour or pungent in the morning. So like having something like raspberries or blueberries or strawberries,
Mm.
something that's cold in the morning, drinking really, really, or chewing the ice in their iced coffee, or chewing ice in the morning while you're getting ready, or again, the list goes on because there's been so many different iterations
Hmm.
of this lifestyle that we've built in. That's what really is comfortable for folks or what they need.
Yeah, you're building this with each individual, obviously. It's not
Yes,
like every single
exactly.
person needs to do this, this, and this. Yeah.
Exactly. But I will touch on some like common snack things or things that have worked for folks because just of how, I say alerting, but how intense of a sensation it is that really brings folks back to like the here and the now.
Hmm.
And maybe not choosing to engage in self-harm. But yeah, we go through morning, midday, evening, and then obviously in the evening, there are things that we still want them to be grounding and enough sensory input, but we're looking more at like the soothing things. So sometimes getting a lot of proprioceptive input at nighttime, we're not going to be doing, intense exercise, but we might have, I would put sometimes people would want a lot of weight. So we'd
Yeah, like a
use like
weighted
2
blanket.
weighted blankets, or like
Right.
having the weighted blanket and then having like a weighted animal or something else, or wrapping themselves up tight in the blanket.
Hmm.
Sometimes wearing, I know it doesn't seem comfortable to some people, but wearing really tight like leggings
Mm.
or a shirt to bed, like a compression shirt,
Interesting.
or a really tight sports bra felt comforting for folks,
Hmm.
even during the day. But if they really needed that input, yeah, I'm trying to think of some other techniques in the evening. But again, really individualized with some similar themes, as I mentioned, the proprioceptive input being one of them, that pressure, weight, or muscle resistance. But we got really creative even on the inpatient units because we might not be able to get access to all these things. But we would just try to get as much of the input throughout the day. And sometimes folks needed, which was a really hard thing for other professions to see because of that stigma, like I talked about at the beginning. Some people needed what we call co-regulation, so somebody else
Right.
doing this with them.
Yeah.
And I don't know why, but like once you turn like, I don't know, I'm gonna say like 8, 10 years old, maybe even younger, people are like, you should just be able to regulate
Hmm.
yourself. Like, what are you doing? Like, figure it out. And for a lot of folks with trauma, but particularly folks with BPD, because of the intensity and the sensitivity and the avoidance of even just an internal feeling is so difficult in that moment to just on your own, because when you're in that state of fight, flight, freeze, fawn, that distressing moment, you're not able to connect to the front part of your brain. You're neurologically just not able to. So the only way to feel safe and grounded is to connect to our back, our animalistic brain, and make that feel calm. So if you can't think of what to choose in that
Yeah.
moment, somebody else prompting or giving something to you and doing it with you, people were not happy. Other folks in the treatment team, were not thrilled at this idea because it combated with or conflicted with that model of, as I don't know if you're familiar with that idea of like benign neglect and like not engaging with folks when they're in distress, folks with
Yeah, which
BPD,
is
and
bullshit in my opinion. But anyways.
right. So I was like, we're not like, I am helping this person feel safe in their body so that they can function. That's the goal.
And you're modeling behavior that you want them to have, which and it's also good for you at the same time. Like, it's a win-win. Let's just do the thing. Yeah.
So some people needed co-regulation. Some people could carry out their some folks that we worked with could carry out their lifestyle plan independently. And that was really something that I think, or I feel strongly that OT is really a key, I don't want to say factor, but just our lens of being able to see cognitively, like, and functionally, can this person do this independently? Or what types of assistance or support or modification do they need? Like, some people needed a printout laminated of the lifestyle plan.
That's what I would
on their
do,
wall.
100%.
Right.
Yeah. I used to have that of like self-soothing on my fridge, and I would check off all the ones I'm willing to do. 50% of the time, this was like years ago, but like 50% of the time I could do it on my own. 50% of the time my husband had to grab the piece of paper and say, here you go, this is what you said that you would be willing to do. And like, that's not hard. We can help people. We don't need to not help people. That's not the job.
Right. So, So some people, tracked it in their journal. Some people tracked it on a laminated sheet with an expo marker. Some people needed me to be like coming in every day with the thing on the wall the whole week, and we were tracking it. So again, just the idea of OT being involved in this as a way to understand, okay, what is going to help this person be able to do it as independently and as safely as possible, and essentially, right, to allow them to do the things they want to do and the things they need to do. So yeah, and then I don't know if you want me to talk about any of like just a couple of the snack things of like the crisis.
Please.
So some of the more consistent like snack things, or the things that in crisis folks really benefited from, was not just, I know DBT tip skills uses temperature, right? Ice. We would prompt a vasovagal response, essentially, by
like
having them dunk.
Reflex.
Yeah, the diver's reflex, dunking their head in ice cold water, covering their neck and their head with ice packs or frozen washcloths. Sometimes it was, this was more outpatient recommendations that folks, would tell me later, but we can't have like metal on the inpatient units. But those like metal massage tools, like the round edge ones, people would put those, and that's a really helpful one, putting in the fridge or the freezer so they're ice cold and holding it, but then using it on like your arm or on your leg, so you're getting the temperature and the pressure input. A lot of taste and smell worked really well. So sometimes every time I would gag, but the frozen lemon wedges work so well.
People swear by really sour stuff.
Yes. Yeah. And candy, right, helps throughout, like sour candy sometimes helps throughout the day, but there's nothing, actually I shouldn't say nothing, because there were other things that I forced myself to do in these moments where I was like, I'm gonna just put the wasabi paste in my mouth, and you're like, oh my god. But to other people, it was hot sauce packets. We would do ginger works really well, like minced ginger or ginger, pickled ginger. So like all of these things, we built into snacks, which essentially are, I think about this one young woman who would try to eat toothpaste because of how uncomfortable it felt in her mouth, and how the mint and it was so, like, that to her was so grounding, but it made her feel so sick afterwards. And I was like, okay,
right, what
can we do so we're not eating toothpaste and we can still get that uncomfortable sensation? So we like put, those like Listerine strips.
Yes, yeah.
Put like 3 of them on her tongue and just like held it there. And so just
and those are intense.
So like just small adaptations to what they were, what folks were doing, so that they still got some of the same sensation, but they weren't making them, it wasn't making them feel worse later or wasn't leading to longer standing functional impacts. So yeah.
That's so cool. Well, first of all, have you seen, just like random thought, have you seen the little girl eat wasabi on like the GIF or the meme, and then she goes like, "Help me." Or whatever. Have you seen that? It's the cutest thing in the
so.
Oh my god, I'm gonna try and send it to you because it's so funny. And like every time I like see wasabi, I think about it. She's so cute. But do you have like a list anywhere of like all of the things that you've found really help for people, like a big kind of like brain dump that people could choose from? Because if you don't, you should.
I feel like at this point I should. I could probably create one because I have all the sensory lifestyle things planned with the snacks. But there's also a really great resource. I'm blanking. I think it's Columbia University out of New York. Created and I can send that to you too. It was what I used early on in my OT career before I started feeling more confident in my skills of taking on this role and being creative in it. But they had broke down non-suicidal forms of self-injury into categories of emotion and different sensory techniques. It didn't cite anything about specifically BPD or what were some of this more sensory modulation stuff that we were talking about today. But it does have it's like 2 or 3 pages of bulleted things of anything from like ripping up a phone book, but like who has a phone book anymore?
Yeah, I was gonna say that's like half of Marsha Linehan's stuff nowadays. You're like, this isn't relevant anymore. This doesn't exist.
I know. But yeah, no, that's really, I mean, even just having a list published somewhere might be an easy first thing to do.
Yeah. Well, and then it also helps people choose from something, right? Because I think part of the issue is like, if people listening to this, for example, they're not working with an OT, well, some of them might be, but they're generally speaking not working with an OT, but they might be like, oh, I really want to incorporate some of these things, but I'm having a hard time brainstorming what they could be. And so one of the things that I did with our Skills Lab self-soothing session was we all brain dumped for each sense all of the things that we would potentially do. And then the homework was basically like try 2 new things from each category.
Yeah.
And I don't know if people did it. You don't have to do the homework in Skills Lab, but it's like helpful to have other people's ideas of what worked for them, because then otherwise we just get stuck in our own patterns and we don't necessarily like branch out. And maybe you branch out and you find something that's incredible that you've never thought of.
Yeah. Look at you, Lori, doing OT work in your doing
my peer support life.
Yeah. No, I love that. And I think you're absolutely right. And that's why I try to do groups on this, even if we don't do the sensory profile with everybody. Just like, what are things that are soothing that works? What are things that alerting that works? Because some people say this like wonderful idea and then I'm like, I've never thought about that. I'm going to try it. Yeah.
So, you know what? I'm going to send you the list because like there were some things on there that I literally would have never thought of. I'll send you the slides that we created together from the self-soothing thing, because it may even give you ideas. I can't think of any off the top of my head right now, but just like of random things that people do that I just think is really awesome. Well, is there anything that we haven't talked about that you really wanted to get into today?
No, I'm really glad that we were able to at the beginning like talk about why I feel this work is so important. I know it's like not the, world according to Maggie, but I think
if that's your stance, then it is. I like it.
Yeah, I it just makes me grateful to have this opportunity to connect with you, and also hopeful that not just because it's like my work and the work of OTs, but this work of how we can not be in a setting, a healthcare setting or a clinical setting, and for somebody who has I'm going to say professional authority, but the professional power in the discussion or the treatment to use the words manipulative or attention seeking, and that even though this is not explicitly breaking down stigma, I mean, I know that's what this is, but that these types of conversations, this type of work is something that's, thought of before. It's just labeled as something we can't support or we're not going to support, that it's behavioral versus saying like, oh, this is a behavior that we can intervene with and let's get, XYZ clinician here to like look at this and to support this.
And a behavior we can learn from. Like, I feel like the word behavioral gets thrown around so much and it's like, right, but why are they behaving this way? Like maybe we need to figure that out first, and that will help us, like you said, do some sort of intervention that can help it in the long run.
Right, exactly. And I know, like you said, we talked about that at the beginning, but I'm just really grateful we were able to touch on that because I
Mhm.
think that's, the why this matters, not just because it's cool.
Yeah, it is really cool though. It's super cool, and it's all what I love about the sensory lifestyle thing is it's also not hard to do.
No.
Right? Like we could all do this. And
Yeah.
that's, I think sometimes you go to these conferences and they have presentations with like all these things and you're like, okay, great, but am I ever going to actually be able to implement this into my practice?
Yeah.
Whereas I saw your presentation and I went, oh, I could implement this into my practice tomorrow. I could
Mhm.
implement this into my practice today. And
Mhm.
like, it's so refreshing to have something like on the ground that you could actually just like make a change for people instantly and help them so much in the long run. So I so appreciate your work.
Thank you. Thank you. And thanks for being so adamant about, wanting to continue this conversation because I think the more that not just me, but just people in general. And I think the more people know of what OT can actually do in this
Yeah.
setting is really important. And for OTs to feel empowered because as a baby OT, I was like, what? Like, this is something I could address. What? And then
Yeah.
now, I know that I still consider myself a baby OT, but that,
But you're Dr. Baby OT now,
yeah,
so that's
Dr. Baby
okay.
OT, you know, this is why we go to graduate school so
Yeah.
we can think critically and we can think creatively and help with I'm going to use the word problems, but it's not like help with what we're supposed to be helping with. And anything that interrupts function and self-harm or self-injury being one of them is something that is definitely within our scope, within our domain,
Hmm.
and it's a response. I think, and I'm gonna say this, and I hope it doesn't offend any OTs out there or any clinicians, but like this is our responsibility. That's
Yeah.
why we do this work, and it disappoints me when people, like I said, look at the behavior or look at somebody or encounter somebody with BPD and say like that's not my role or that's not something I'm going to engage in or not even going to get engaged with the person because of what they're doing. And it's, yeah, I don't want to end on a sad note because I don't think it's sad, but just a sense of empower, like having folks feel empowered. And particularly, I hope if there's OTs out there listening too, or even like people with a BPD diagnosis, feeling empowered to ask and search for an occupational therapist in the
Yeah.
community, like finding a psych OT or finding an OT who would be willing to do this, work with you if you want to, if that's something you're interested in. I'm a big believer in, like feeling empowered. And yeah, I think this work hopefully does allow people to feel more empowered in their life by engaging and understanding themselves, their sensory selves, or just themselves in general. And like you said, a routine or something that's going to help you
Hmm.
feel empowered throughout the day. So,
Yeah, absolutely. Okay, well, my final question, I always end it on a positive note, so
okay.
don't you worry. Not that that
Oh,
wasn't a
good.
positive note, that was beautiful. But what is your favorite part of working with people with borderline personality disorder?
I saw an interview somewhere on like Instagram, some like scrolling the one time, and it probably pops up on my feed because this is the work that I do and the things
Yeah.
that I talk about, which is, scary in and of itself. But
Yeah.
anyway,
That algorithm knows everything about you, just so you know. Yeah.
exactly, exactly. But it was a conversation with a clinician who worked with folks with personality disorders, but BPD in general. And they said that one of the things that folks with BPD often trigger in other people is this idea of being authentically like responding, like this a sense of honesty, and
Mm,
that can trigger other people because they pick like people with BPD, or at least in my experiences working with people with BPD, they pick up on nuances or things that of somebody and bring it to the forefront. And I'm a big believer that if you're not aware to something, then you're not doing good service to yourself or I guess in life. If you're not aware to something, then it just prevents you from growing, from learning. And I think one of the best parts about working with folks with BPD is the just the genuineness and authenticity in every interaction that I'm in, whether it's like really difficult or really, great or awful. And I value authenticity and genuineness and bringing that out in me and bringing that out in the world and bringing that out in themselves. And so I would say, yeah, while other people might feel triggered by it, I feel like I don't want to use the word endeared, but like I or admired, because it sounds like I'm speaking in a down way towards it, but it's just something I just really appreciate and have gratitude for in the space of healthcare and just in the space of life, to have authenticity and genuineness, even when it's uncomfortable and difficult. And yeah, that's probably what I'd say.
Well said. Well, Maggie,
you.
Thank you so much for everything that you do. This work is going to make so many people's lives better and change clinical practice for so many. So I appreciate it so much, and great to have you on.
Thanks so much, Lori.
Thanks so much for listening to the Superfeeler podcast. This episode was recorded on the unceded traditional territory of the Matsqui and Sumas First Nations. If you'd like to support the show, you can find bonus content on Patreon or donate directly on PayPal. If you're looking for peer support and joining the best BPD community out there, you can sign up for the Superfeelers Club or Skills Lab sessions for free at www.superfeeler.ca/peer support. If you enjoyed today's episode, please subscribe, leave a rating or review, and share it with someone who might find it helpful. It really does make a difference and helps more people find the show. Truly, that 5-star rating means way more than you think it does. Don't forget to follow me over on social media for announcements, show clips, and more. You can find links to everything over at my new site, www.superfeeler.ca. So much easier to remember than my hard-to-spell last name. Until next time, take good care of yourself and keep on superfeeling. Lots of love, and thanks for listening.